Continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIB is funded by the National Lottery Community Fund.
Good morning. My name is Lizzie. I'm an A&E doctor, and it is my pleasure to be hosting this week's episode of Health Hours. Today, we're going to be joined by Dr. Kamara, who is an A&E consultant. He's been in A&E for over 20 years, and he has also got lots of experience from surgery and orthopedics. So we are very honored to have him joining us today, talking about asthma, a very important issue, a very serious condition, and he'll be giving us facts, information, and advice all about it. You'll have the opportunity to ask lots of questions, so please put your questions in the chat. I will come to them at the end of the presentation. So it is my honor to welcome Dr. Kamara. Thank you.
Thank you very much for that. See, where are we? Why am I not able to do? It was working.
Please give us a moment as we set up the presentation.
Yeah, I'm trying to load it, but for some reason.
I just wanted to share that this is a topic that's close to my heart as well. Here I am with my pump for asthma. Luckily, I don't have to use it very much, but I'm sure Dr. Kamara will speak to us about asthma pumps and all the different devices.
I don't know. Am I still with you?
You're still with us?
All right.
Yes, you are, Dr. Kamara. No worries, these things do happen.
Can you see that?
No, not yet. We're just trialing it. It happens.
Yeah. For some reason.
We just wanted to say hi to everyone that is in Gorton as well, in the Gorton Hub. Gorton Wellbeing Hub has been on for some time now, where we welcome mothers, parents, and people from our community to really invest on their health and well-being, be together, connected.
Yeah, thanks so much, Natasha. We're all here and we're also giving you a loud shout. Thank you so much. And the topic chosen this morning applies like it's relates to so many people, and we're excited to have the session with Dr. Kamara. We have children, asthmatic children here in the room, and even the person speaking to you at the moment is also asthmatic. So it will really be nice to, and just as Dr. Kamara was mentioning earlier before the session started, that it would be nice to have lived experiences, because you can't really understand till you see somebody in asthma crisis or it happens to you. So I'm that one person that can say so much about asthma. It's a very, very terrible situation. And I saw Dr. Liz with her pump. Dr. Liz, also asthmatic, right? So we are so many in the room that are asthmatic, and waiting for Dr. Kamara to give it to us this morning.
Yeah.
Tips to stay healthy, tips to prevent it from happening in the first place before we get into the crisis.
Absolutely.
I think,
So,
unfortunately, when I'm working in PEDS A and E, we do frequently see children with asthma who are coming in wheezy and short of breath. And actually, it's one of those things that it's better if you bring in your child slightly earlier. So it's a condition that can be well managed, but it's recognizing the signs when it's something more serious, when your child is particularly suffering. And in hospitals, there are lots of different medications that we can give. So people do start off with the basic pumps before going on. I think we maybe have a presentation starting soon.
I'm not
okay.
even sure.
Sam, do you know if you can support Dr. Kamara somehow?
Yeah, Dr. Kamara, if you don't mind, just either sharing your slides with me, and then I'll just put it on the screen for you.
Sharing the slides, I don't know what's.
Sorry about that.
No, that's okay.
Yeah, but Dr. Liz, back to what you were saying. Well, personally, sometimes you don't know when it just starts. Like you were fine the previous day and you didn't know, and you just have a sudden breakdown the next day. So how would you be able to, you said you bring them slightly earlier, when sometimes there are really no warning signs, and sometimes it's very easy to mix it up with common cough or cold.
Yeah.
So how would you be able to,
So I think the main thing to know is, what is your child normally like? Asthma is a problem that affects your breathing. So your child might be someone who's very active, who runs around a lot, who's always talking. Sometimes the initial signs might be a little more subtle. They're not able to do what they normally can do. And even when you're talking to them normally, when they'd be answering back full of conversation, you see that they're struggling a little. They might not be completing all of their sentences properly. Those can be some of the later signs. Sometimes you can even listen very closely to your child as they're breathing, and you'll notice that there's a bit of a sound, a wheezing sound. Sometimes it can sound a little musical. Those sorts of things are definitely signs where there might be something going on with your child's breathing. And also, when you look at the way they're breathing, especially with young children, sometimes we'll have a look at them with their tops off, and you can see their breathing pattern. And the way their chest will suck in, you know that they're working quite hard. So it's about knowing your child, knowing when they're not doing their normal things, having a listen to the way they're breathing and having a look. Children sometimes will have quite obvious triggers. It might be things like animals, like cats, like dust around. It might be that there's cleaning, or you're asking someone to sweep and suddenly their breathing changes. If you do have a pump like this, then it can be quite easy to start off by just administering a few pumps. Normally you do see an effect quite quickly, and you might need to go back to this. So people will be at home and having up to 10 puffs of this. If 2, that would be normally the standard way you start off with if you already have an inhaler. And if 2 doesn't work, then you keep going. But you need to take that child in to have a medical assessment. This does not work forever. It is very good, but it's not something to just keep taking puffs at home. There's a whole range of asthma medication, and depending on severity, then there'll be more medication that can be added, even tablets if necessary. So, sometimes you have to recognize the triggers, recognize your child. And it looks like we've got the presentation in front of us. I can see the slides.
Thank you so much, Dr. Liz. That was quite insightful. I think, yes, everybody in the room, thank you for staying with us. I'm sure you enjoyed our shared lived experiences here. And hopefully Dr. Kamara will be ready to present. Yes, he looks more than ready.
Sorry, apologies for technical issues there. I think it's can you hear me?
Coming through clearly.
Right, okay. So as is asthma, as has already been said, is a very, very important topic. It's such an important topic that the World Health Organization decided to, if you like, assign the 7th of May as World Asthma Day. The reason for that is, I just give you a few key facts about asthma, is that it is possible to have asthma without knowing it, especially if the symptoms are mild and or atypical. Now, we've got to Liz, who's just alluded to that in the conversation whilst I was trying to set myself up. But these are the signs that you would probably see or maybe need to observe in order to think about asthma. Someone who's a baby or an adult who's having persistent cough, you can hear them wheezing, like the whistle blowing. They're either short of breath when they speak, they can't speak in full sentences, and they tell you that the chest feels tight, making it very, very difficult to speak or to breathe. Now, asthma, I don't know if you know about this, is a non-communicable disease. As I've said already, you may have it, and you don't even know you have it until you actually end up in hospital. Effects and other non-communicable diseases we've talked about already. I think I have talked about adult asthma on this Kathy Power, and this, therefore, I decided to do one for the children. So it affects both, adults and children alike, and it's the most common chronic disease in children. It affects an estimated 262 million people. That was in 2019, just when the COVID was setting about, if you like. And I think it may well be a lot more than that. I don't have the most recent details or data, but definitely because of COVID and COVID being chest related, clearly that figure would have gone up. There is definitely medication available and important for those who are asthmatic or who are suffering with the symptoms to avoid the triggers. And you only would avoid them when you know what they are. And for you to know what they are, you definitely need to have a health worker who specializes in that. So the reason for talking about it is that asthma kills. Literally every minute of the day, there's somebody that dies of asthma. Hence the reason why WHO decided that, look, need to be sitting up and making sure people are alert and they know what asthma is about, that it can kill. If you're not careful with it, because when we go as medics, we do have airway, breathing, circulation. When you approach a patient, you always go ABC. Now, airway is the top one, which will kill you first. Breathing is not far off. So asthma affects both of those. And so therefore, asthma kills. No questions about that. So in the US, it's very prevalent. Surprise, surprise, amongst us. Puerto Ricans, African Americans, Filipinos, and it's actually lowest amongst the Koreans, as you can see in the picture on the right here, the slide. You can see that under 10%, over 10%, you can see in all of this region, and about 10% you can see in the pink regions, as you can see. And there are regions where the data may not be accessible, and that will talk about. So, as you can see, the economic in my country of birth is like 108, and the GDP, as you can see, is 34, and per capita is 10. But when you look at it, it costs about $80 billion just in medical expenses, days work, days missed from school. Because when they is unwell, they ask her to pick up from school, from kindergarten, and then of course end up going to the GP or going home or going to the A&E. It's what the Americans thought. Can you imagine that? So currently in the UK, the world, we're estimating it to be between 2022 and 2031 to be 47 billion pounds. So it just goes to show you, it's a big, big drain. Financial impact is indescribable. This is just the details, the data of Sierra Leone that I mentioned already. Out of 600 deaths, you can see that 1.01% is what is attributed to asthma. The problem I have is that if you look at number one here, It's influenza and pneumonia, and then asthma is on 24. The problem is signs and symptoms of influenza and pneumonia are very similar to the ones of asthma. So the question is, how sure are we that this is not because of asthma? I'll leave you to think about that. But I thought I'll just throw that in just for you to see it. So this is what they do in Sierra Leone. They've got this support group in Sierra Leone that helps people with asthma and COPD. And so if you have any way of, maybe donating, by all means, the link is there. You can be generous and kind and do that, please. So, as you can see, the prevalence of asthma in childhood in the world is 11% between the children aged 6 to 7 years, and 9% among the children who are a bit older. This is as recent as last year. So it just tells you that over 10% of children at the age of 6 to 7 do have asthma. It's really, really important for people to know that. As I said again, amongst, the population of the world that is affected, you can see the African American is 12.7, and the Puerto Ricans is 25.7. The whites or the Caucasians are 8.8. Now, as you can see, it is highest, i.e. asthma is highest in the children or people or the population that are living beyond and below the poverty threshold, those who are in an urban setting, and those who are in the northeastern portion of the US. So it's an inflammation, as you will asthma, if you describe it. It obviously causes problems with physical activities, daily ones, the ones that you do normally without even taking notice. They become a bit of a task, they become a bit of a burden. And so you can see that, as I said, 25 million people have asthma in America, commonest chronic condition in children. One child in 12, which is really, really a big number, has got asthma. It is important to remember that asthma kills. And so therefore, you need to know what the lung, if you like, is looking like on a diagram when you cut it in half. This is what the picture here is showing. You look at it, this is what it is normally. So the muscles, you see these rings, that what we call, they begin from the windpipe up here in the front of you, what's called the trachea. The trachea, when it gets to that divot in the middle of your chest, it then divides into the right and eventually on the left. The right is divided to two, which are the bronchs, and the right is divided, the left is divided to two, and the right is divided to three. The reason for that is because the heart is on the left. And so those then divide into bronchioles, smaller ones, and to the end, bronchioles, smaller bronchioles, onto the end, you have the alveoli, which is like a sac, which is where the exchange of the gas takes place. So when you get in the oxygen to come in, and then you get the carbon dioxide to be taken away, that's what it does. But if you look at it, you see when it's relaxed here, you see the ring of muscles, you see it's relaxed. Compare that to when you have an asthma attack, you can see it is swollen. Yeah, swollen, and therefore you get that whistling sound, which is otherwise called a wheeze, because it tightens it. Doesn't completely block it, which is different from when you have like an infection. Infection would give you some secretions, and then of course that would block that, and therefore causes the problems with breathing. However, this one is the muscle, it constricts because of the inflammation, and therefore causes that whistling sound. But when you look at what the medication does, you can see how it surrounds it and it reduces the swelling. So it just goes to show you, look at that normal, look at that swelling without the medication, and compare that to when you have the medication. All right, so you can see, again, the picture here shows you, because of that swelling, the inflammation causes the bronchioles to release this secretion, which is like mucus, and that in itself causes problems with the breathing. So what do you have? It's a lung disease, it's chronic, and if anybody tells you they'll get out of it completely and not get anything later on in life, well, I'm not sure about that. You might have the mild form of it, you might have the intermittent form of it, but it doesn't mean once you've got it, it means you will get it cured. However, you can manage it properly. I know people who are very, very prominent, who are very, very, if you like, good at their work. Someone like Paul Scholes, who used to play Manchester United in England. He was a full-blown asthmatic, but he used his medication well before he went into the field, into the grass, and he did well. As everybody knows, he's a legend. So it is manageable, and you can live with it, and you can live a fulfilling life with it. It's just when you look at it under the microscope, you will see on the right, you see when it's swollen, and you see on the left what it should look like when it's normal, when it's in the state of norm, when it's not inflamed. So we said this already, that is the commonest, non-communicable disease in children, and it's also common amongst the adults. It's definitely more prevalent in the low to middle income countries where they suffer disproportionately high asthma, and the morbidity and the mortality is quite high. So what does it lead to? People who have asthma know this. It affects you mainly at night. This is why the children, when they start coughing, so mothers and fathers, take note. If you have a child who around 1, 2 o'clock in the morning wakes up coughing and can't sleep, sleep disturbance. And followed by that, you have tiredness during the day, and they concentrate very, very poorly because they're tired. Then you know, even if it's not diagnosed, you probably need to seek attention to actually get assessment, whether it's possible that it's asthma. Yeah, they miss school because of that. And of course, the moms and the fathers or the parents do need to get them. And obviously, in that way, they then end up losing financially. So it is not only affecting the child or the individual, but it affects the whole family and, of course, the community as a whole. Yeah. If symptoms are severe, then obviously, please do not wait until it becomes extremely serious, whereby it's life-threatening, and by that time, it's a touch and go. Once you see the symptoms, as Dr. Liz was saying, use your pump as you should, the inhaler, and if you use it once or twice and you don't get any response, then begin to think, hang on, perhaps I need to seek help. Don't wait until you actually get to a point where you know, death is around the corner. It's not going to be good. Therefore, a stitch in time, literally in this sense, saves 9 because it kills. So, as you have the classification. If you want to describe it or define it or whatever you want to divide it as, you have the one which is intermittent, and you've got the persistent. So the one that is persistent is there all the time. But with the persistent one, you've got the mild version of it, the moderate version of it, and the severe version of it. The intermittent one is the one that comes and goes as and when. So you've got intermittent with symptoms less than 2 days a week. When it's mild, it's more than 2 days or maybe 2 days a week, but not daily. And then the moderate one, you have the symptoms daily. And of course, the severe one, you have the symptoms throughout the day. So you can see that it's divided in not only the interference with normal activity, as you can see, when it's extremely bad, it's limited to the point that you can't even function. When it's moderate, you have some limitation. When it's mild, you have minor limitation. And when it's intermittent, you have none at all. And the lung function, you might not know about this, but that is for the ones who are medics. They know that that's one thing we measure. So the exacerbations of it require medication. So under the 1-year-old, that may sometimes be the intermittent one, but consider the severity and interval since the last exacerbation. Is actually that would actually determine what type you have, whether it's now moving from mild to moderate to severe. And it's important to remember that if at all, when you're doing the medication, i.e. using it, you have in 2 to 6 weeks, you evaluate the level of the asthma control. So if you start taking the medication, within 1 week, you'd obviously get to see whether you're improving or not. And within 2 to 6 weeks, you will know how well controlled is it. Are you going back to where you were normally, or are you worsening? And if you're worsening, then it needs to be sorted out, definitely, by the care worker, and sometimes with us in the ED. So with an asthma attack, I mean, those who are asthmatic will tell you about it. I talked about the bronchs, the trachea, which is the windpipe, breaking down into the bronchs, and the bronchs breaking down into bronchioles, and the bronchioles breaking down into smaller ones and smaller ones until you get to this sac I was talking about, the alveoli, as you can see there. This is where the gas exchange takes place, the oxygen for the carbon dioxide. So when it's normal, this is what it looks like. You see, it's really nice, smooth, wide. Here, you see, it goes into spasm, which is what happens with the inflammation, the asthma attack. It begins to the mode of producing this thick mucus, which is then causing constriction, which is causing problems with the breathing, and of course, functionality. So this is the normal lung, as you can see it, and that's what it looks like when you cut it. And this is the asthmatic lung when it's in full flow, and you can see the swelling and the excess mucus and the tightening of the muscle. So, signs of an asthma attack, we've said that already. The symptoms worsening after you've used your pump, yeah? And intense wheezing, sometimes coughing, and inability to catch your breath. If your chest is getting tight, or you feel pressure in your chest to the point where you can't speak, you look pale and sweaty, definitely that is to tell you that probably the blood pressure is going down, and so therefore it needs to be sorted out in a hospital setting. The earlobes and the lips and the fingernails can get blue. Now this applies to people more who are Caucasians. I hasten to say, because us people of color, the Afro-Caribbean, the African American, it's very difficult to distinguish color when it's blue. And that is a late sign. So therefore, look at the other signs, look at how the person in front of you is feeling, which is not their normal self, and treat them as you should. There's a video here, which I hope you'd enjoy.
Asthma is a chronic long-term condition that can be managed but not cured. Asthma affects the airways of your lungs. It causes the airways to narrow and swell, resulting in wheezing and difficulty breathing. During breathing or respiration, air goes in through our nose or mouth to the upper airways, at which point it reaches the windpipe, which branches into two large bronchi to reach the lungs. The lungs are protected by the rib cage, which also contains the muscles that control your breathing. In asthma, the airways are oversensitive and easily irritated by certain triggers, called asthmatic triggers. Most people with asthma are described as atopic, meaning they have an allergic type reaction to external triggers, such as house dust mites, pollen, cigarette smoke, animal fur, and chest infections. However, for some people, the onset of asthma is unpredictable and may be caused by anxiety, stress, or even laughter. An asthmatic trigger causes the airway walls to swell and the muscles around the airways to contract. The airways narrow, and breathing through them produces a whistling sound called wheezing. Mucus is produced from the lining of airways, clogs up the narrowed airways further, and causes coughing. This makes normal breathing more difficult, producing symptoms of asthma that can be mild, moderate, or severe and life-threatening, where hospital treatment is needed. The narrowing of the airways is reversible if the trigger is removed, or if the inflammation is treated medically. Therefore, preventative treatment is used and can be managed by the patient themselves. An acute asthma attack requires medical intervention, but the type of intervention depends on the severity of the attack.
There you go. I hope you enjoyed that. So, what are the causes of childhood asthma, or asthma in general anyway? Obviously, you find it a lot more prevalent, in fact, 3 times more possible to have it if you have a family background of it. So genetics has a very, very important role to play. Obviously, allergies. So children who've got hay fever, who've got eczema and asthma, we call them atopic children. They're likely to develop asthma. Infections of the chest, respiratory infections in children can increase the risk of developing asthma. And of course, you've got environmental factors. I think I remember for the very first time in the UK, there's a little girl who was being carried by their parents in a car in the London traffic, and the fumes and all the pollution and all that caused her to develop this chronic chest problem. And she was the very first one that they said actually the coroner ruled that she died of air pollution. So it just goes to show you that it is something that kills. People who are overweight definitely are more likely to develop asthma. So it's obviously nice to be active and keep the weight in check. And of course, we talked about pollution already. Mothers or would-be mothers who are smoking during pregnancy have a higher risk of the children becoming asthmatic. And of course, viral infections we talked about already, and the allergies we talked about already. So this is also just a picture illustrating that air pollution, viral exposure, smoking, genetics in particular, indoor allergen exposure, like the mites, the carpets there, the pets, all of these are definitely risk factors. There's no questions about that. There you go. This one just tells you. And the reason why we in the low to middle income countries or maybe populations suffer more with that is because of the living conditions we're in, what we find ourselves in. As you can see, molds, dusts and mites, because of that, where we live, you have the industrialized areas. Because of that, we are prone to infections. The additives, the kind of food we eat, and smoking is more prevalent in that. And of course, stress, anxiety, and the pets, and sometimes even exercise can actually trigger. Oh, this is very important. It just shows you the health disparities in asthma. It goes to tell you about the literacy and the cultural beliefs, how they differ from the individual level to the societal levels. You can see the pollutants, indoor and outdoor. You can see the socio-cultural factors. You can see the stress, vitamin D status, that's another one, especially when COVID was around. And of course, the housing conditions. More importantly, is the education. What it is we do about it. How do we educate people? How do we sensitize them? How do we get them to be more aware that, look, asthma kills. Asthma is a non-communicable disease, and it's here affecting us more than the other ones who are affluent or who are rich. So the symptoms are, as we talked about already, we've actually gone through a lot of them. We talked about the coughing, especially at night, and when they're laughing or when they're out to do their PE or exercise. It's important to remember that. Tightness of the chest, shortness of the breath, and of course, difficulty talking and when they're exerting themselves. Anxiety, they become, anxious and they panic because they think, oh, there's this pending feeling of doom, and they become fatigued because they don't sleep at night. And of course, they sleep in the day and they can't function at school. They can complain of chest pain because they're coughing, because the muscles between the ribs and the intercostal muscles do get to collect lactic acid, and that causes pain. The wheezing we know about already is the constriction of the muscles in the bronchioles, and they will breathe fast. They could have infections which are on the increase if they're not treated. We talked about the trouble sleeping, and of course, the very, very young kids, the children, the newborns, maybe up to 1 year, they would have problems sucking or latching onto the breast, onto the nipple, because it takes a lot out of them to actually suck, breastfeed, because of the fact that the chest is not aerating properly. It's not getting the enough oxygen because of the constriction of the muscles. So we've got different types, as we talked about already. We have the asthma that is due to allergy. We have the asthma that actually affects them more at night. We have the non-allergic asthma, which probably could be because of an infection. We have the cough variant, So people, the children will just cough, 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 and you don't see anything else. There's nothing else, but maybe they have asthma or they have asthma in the background in the family. It's important to do that. In the adults, there is asthma overlapping with COPD. So the ones who smoked for a long time in their lives get COPD, and so therefore sometimes it can overlap. And there are people who've got heart failure who've also got symptoms of asthma. That's what we call cardiac asthma. Yeah. And then, of course, exercise-induced asthma, like I told you already. And of course, we have certain medications that can induce asthma. Some of them aspirin, things like ibuprofen and things like that could actually trigger that. And of course, that is similar to something like what we get with anaphylaxis or angioedema when we do take some medication, like ramipril, which you take for blood pressure. It's very important to remember that this can cause that. But of course, if you get sorted out and assessed by the worker, the healthcare worker who is a specialist in this, you'll get better and you'll be able to control your symptoms better. Now, the symptoms vary from person to person, as you can see. People may have a mild case, whilst others suffer from a moderate case or a severe case. And you can see the different ones we talked about already. You know yourselves, those who are suffering with asthma. Those who've not been diagnosed, you can see the symptoms worsening. And so therefore, you need to be taking them to the appropriate departments to get them looked at. So if you look at the severity, you can see mild, moderate, severe, and moderate persistent. You can see that twice a week. If you get that, then maybe that's mild, but that's intermittent. But if you get it more than twice a week, then it may be mild. But then if you have it daily, then it may be moderate or severe, again, depending on how you feel. The symptoms you might get at night. If you get it twice a month or less, then it might be mild, intermittent. If you get it more than twice a month, it may be mild. But if you then get it every week, at least more than once, then it's moderate. If you get it more often than that, then it's severe. Again, the effects, you can see the lungs for someone who's mild, intermittent are fine. So they have periods when they're okay, and then they get flare-ups. Maybe they go out, get wet in the rain, or they get a bit of a cold, and then gets triggered. The mild persistent interferes with your daily activities, but not as it would when it goes to moderate persistent, and then, of course, to severe. Severe will definitely deplete your reserves to the point where you can't function. And therefore, they need to be sorted out. No questions about that. Children, well, will get better, but to say they will outgrow it or they actually would be cured of it, as the video alluded to, is probably a misleading fact. They can get better, but it means if it reappears later in life, then then that you need to be looking at maybe trying to take your medication so that you thwart it in its tracks. So, what are the complications? There's many, as we talked about it. Poor sleeping patterns, therefore fatigue, therefore missing school days and falling behind in their work. And of course, there may be problems with the functioning of the lung. And importantly, when it gets that bad, remember, the symptoms interfere with your play, your sports, or other activities which you used to do, and it got to the point that you're not responding with your pumps when you use it once or twice, then please think about and maybe even call an ambulance to get you to an emergency department. How do you diagnose it? Well, as you can see already, if you come to a clinician, you would actually be asked to give a full history where you look at how it happened, when it started, how does it affect you? Do you have that in the family or not? Were you premature as a baby? Because prematurity is another risk factor as well. And then, of course, they will examine you properly. They'll look for things like allergies, eczema, hay fever, people who have hives and things like that. And then, of course, they'll do the tests. So the breathing test they will do, but the under 5, it's difficult to get them to do that test. Therefore, they will do the tests of the breathing the pulmonary function is not definitely meant for people who can manage it, and under 5 they can't. But they have other things they will do for you, for your child, and assess whether indeed they are prone to asthma or they do have asthma. This is just a spirometry, which is the machine you blow into for you to be able to be assessed as to whether you do have that or not, or you're prone to it. They do it before they give you the bronchodilator, which is the medication that opens the airway for you, albeit temporarily, for you to be able to breathe. And of course, take a look at that bit where it says in 12%, in 9% in children, it is increased. That's the spirometry. Remember that if you have a normal spirometry, this is important. If you have a normal spirometry reading, which is the lung function test, it doesn't mean that asthma has been excluded. It's just one of the tests. There's a battery of tests, and there's no one single test that will tell you that this person has got asthma or hasn't got asthma. I need you to understand that. So the peak flow, which my colleague was talking about, is important. This is the one that actually I advise all the asthmatics to at least invest in one of these, because this is a guide for you, similar to people who have anaphylaxis, to actually have the EpiPen with them all the time. Because if you get the swelling of the lips and you don't have the adrenaline to put into the muscle, it could be life-threatening. Likewise, this one, if you're at home and you see the child coughing, 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 and not sleeping, then if they're able to do a peak flow, you would have at least, been aware of what the baseline is, what their normal is. And if at all they're blowing into that, you take the best of 3, and it's dipping more than 30%, or maybe even less than that, but they're definitely getting worse, then clearly you need to be thinking of taking them to hospital. So how you do it is quite obvious, that you place the marker at 0, as is shown in number 2 and number 3. People should not be sitting down to do it because it impacts your numbers. So you stand up and you take a deep breath in, and while you're holding your breath, you put the mouthpiece between your lips or your teeth, and then you blow out as hard and fast as possible, as if you're blowing the roof away. And then that should be written down. And as I said, you then do that 3 times, and you take the best of the 3. And that should help you to actually tell whether this is less than what it is or it's close to what it should be. And so therefore you can treat it at home rather than go to the hospital. They have other things they can do. They can do an X-ray of the chest. They can do a provocation test. But this is all for the medics. It's not for you. You can definitely go to the people who are more specialized in this, and they can do what they have to do for you. They have, as I say, other tests. The allergy testing. They can actually do the sweat chloride. They can do the nitric oxide that you blow out, and they can do other tests, because the chest, the shortness of breath, difficulties breathing, is not just because of the asthma. It's important to rule out all the possibilities. And you can see that there is possible. Sometimes you have people who have. If you look at the airway, which the windpipe, which is in front of you, behind the 2 sisters or cousins is the food pipe. So the food pipe is right behind the windpipe. And so sometimes people have connections, which we call a fistula, between these 2, and they can cause shortness of breath similar to asthma. You can get what we call a hiatus hernia, and that hiatus hernia is where the food goes into the stomach. That bit is laxed, and therefore the food can come back up, and that can cause what we call reflux, that heartburn, and that can cause breathing problems. There's also what we call vascular anomalies. There could be the vein and the nerve connecting together, which we call AV malformation, and that can give you that. So there's a lot of things that could be similar to asthma, and so therefore they have to do this to make sure they narrow it down to asthma. So there you go. This is just giving you the symptoms again. This on the right is giving you the risk factors, and this is on the top is giving you the treatment. And on the top left, you can see what it's like. The normal, we know about it already, and the asthma in the middle, how it looks like, and of course, when you have an asthma attack. So you can see that. We talked about that already. What are the disparities? Well, as you can see, access to care in the low to middle income countries, there's a lot of problem, in terms of transportation, in terms of severity, in terms of the income people have. in terms of the environmental allergens that are relevant to the population and where they are. And of course, education, as we talked about already. Language is important. Cultural differences is important. People think it doesn't affect me, or no, I'm immune to it and that. Well, impossible. As long as you have, that tendency to develop asthma, think about it. Yeah, there's definitely a connection between poverty and asthma, and it's due to these, varying factors, as we see. The healthy housing conditions, the poor neighborhoods, as we talked about, these are all things to consider developing our nation and going forward. So these are just the medications that you have. You have the relievers, you have the controllers, you have the preventers, which are in orange. The controllers are the green, the relievers. So when you get the symptoms, the one that relieves it, and then you have the ones that are long acting, which are the controllers, and then you have the preventers. And you can have ones which are a combination of those. So depending on what the healthcare worker finds possible, it's a bespoke management plan for you, not for everybody. It's not one that one cap fits all or one size fits all. No, it's one that is bespoke for you and you only. So these are all the different ones. As I say, cromolyn is one of them. Theophylline is another one. And we need to look at what the signs are of poor control. So as I said already, if you're controlling it, then definitely you want to ensure that this patient is not getting themselves to the ED, which is a sign of good control. But then if you cannot control it well and you have to end up using the ED or the emergency department, then how many times are you doing it? Is it because of poor technique? Is it because of where you live? Is it because of poverty? Is it because of the fact that you've not been diagnosed, or what? Or there's something else that may be causing it? How many times do you get admitted? And when you get admitted, are you admitted to a ward or you admitted to the intensive care? How many times you get to be given the medication, the steroids? Yeah. How many times have you been absent from school? You've been taken away from school. You've been lacking in your work or lagging behind in your work. And of course, how many times have you had to sit it out when you're asked to do PE or physical activities? These are all the signs of control. So if you're not adhering to your medication, you're not adhering to the health advice given, then obviously you would not be improving. If you don't have a good technique, you've not developed it, then obviously you wouldn't be responding. If you have the dose of the medication that you've been given, which is subnormal or suboptimal, it's not up to standard, then obviously it would not be effective in treating it. And of course, the other medical problems which may be complicating the asthma. And of course, people, believe it or not, because of cultural differences, have this thing about substituting the treatment for other inappropriate treatments. We've seen that, and we know that people have died avoidably. People have died needlessly because of this particular situation. And of course, we have the response. This is why I've talked about it being bespoke. Everybody different, the response, different in different ways. It varies from one individual to another. This is why it's important to get it to be for everybody to have their own individual plan, the bespoke plan. So these are all just the inhalers. You can see them. Those who know them know what they're looking at. They know that for quick relief asthma treatment, this is what you need. I don't need to go through them, but you can see them. So this is important because what it does is it tells you what you need to do when you're looking after someone who's asthmatic. So if someone's asthmatic, remember to do this. Assess them. And when you're assessing them, remember the different ones we talked about, the mild, the moderate, the severe. And if the person is severe and you are sensing that this person is definitely not getting better and is really getting to the point where I think they're not well, they really are getting, being tipped over the edge, then remember, your ambulance service is there, 111 or 999. So how do you assess them? You don't assess them standing up. You sit them down and they're upright and you stay with them. So if you notice it's a mild, attack, then obviously you treat them with the inhaler, 2 doses of it, and then keep an eye on them. You then move on to the next step. after you've treated them. So you're allowed up to 6 doses of any of the relievers that you have. Yeah. So when you do that, keep an eye on them. If you think they're not improving, then by all means, call for help. Yeah. Remember, 6 doses of the medication, 6 breaths per puff. So when you take 1 puff, you take 6 breaths, and then of course you wait. You take the second one, and then once you've done your 6 puffs, then remember you have to wait for 6 minutes and then repeat that. So if it's improving after 6 minutes, keep monitoring. If necessary, repeat the doses. If not, then of course, remember 111. I hope this is clear. So you assess them, you know they're in attack, you give them the medication while they're sitting down, you ensure that they're improving, and if they're not improving, you then repeat that. And if they're not improving, you repeat it a 3rd time. By the time you get to that 3rd attempt and you know they're not improving, then remember, you need to be looking at calling an ambulance whilst you're still with them. Don't go away. Nowadays, we all have mobile phones. We can use them. So the long-term treatments, as you can see, we have, steroidal anti-inflammatories, we have long-acting bronchodilators, and of course, we have anticholinergics. These are all things you might not be aware of the names, but they will definitely tell you about them when they manage you. So, big points. These are the points I want you to take home. You need to have an action plan. And for that to happen, you need to have the assessment done to note whether yours is mild, moderate, or severe, and what to do. And of course, you need to be assessed due to the exposure that you may have to allergens. And in so doing, they may have to assess the triggers that you have. They will educate you. And of course, they would review your level of control. And if at all, every 6 months they can do that, or maybe even more frequently or more often. And if at all they find out this is not getting better and not getting under control, then they'll refer you to the specialist. So regarding the dangers of overuse of the beta agonists, you'll be told as well. Some people get to overuse that, and that is not good because it's got side effects. Every of those medication, each one of them has got risks. And so therefore, it's important. They'll also give you information about the risk factors for death from asthma. So finish on this one, but this slide encompasses, it encapsulates the whole talk that we've just had. You can see the types there on the left. You can see when you get the asthma attack in the middle, which is 2, and 3, you can see the risk factors there, and 4, you can see the symptoms there, and 5, you can see how you get diagnosed, and of course, and 6, how you get treated. I'll stop so far, and thank you for having me.
Thank you so much, Dr. Kamara, for that informative presentation. I feel like there's a lot even there that was good for me to go over again, and hopefully there'll be everybody in the audience who found something helpful to take away. Please, if you do have any questions, please put them in the chat and we'll come to them now. We have some time for questions. There was one that started off that was in the chat. Just to confirm, is asthma something that can be cured, or is it a lifelong condition?
Yeah, I think that was answered already. The video actually alluded to that. If you want me to replay it, I'll play it. Like I said, you can improve it. You could definitely be less affected, but to say you are cured, I think is misleading. I've seen people who've not had asthma attacks for 10, 15 years, and then one fine day they caught a cold, and then they needed the inhaler. I've seen them come to me in the ED. Very often they do that. So it's something there. It's a bit, I don't know if it's an analogy I can make, but it's like gestational diabetes. So mothers who have diabetes in pregnancy, they get better and they improve. Some of them don't get anything until when they put to bed. And then maybe postmenopausal, they definitely, 50% of them do get type 2 diabetes. Not all of them. So similar to that, you can get it mild, but definitely to say you're cured, I doubt that very much.
Thank you.
Especially if you have the genes.
So it sounds like something that can be managed. that doesn't necessarily have to affect.
100%. I mean, no, Paul Scholes, as I said, I don't want to, he's one that is done well. He's playing football. He played football, played for England, played for Man United, and he was good at it. He's a legend, but he controlled it absolutely superbly well.
Fantastic. Okay, we've got someone actually who raised their hand if they would like to unmute themselves and have and say their question.
Thank you. Hello. Yeah, my question is if a person has a malampathic 4, if the person malampathic is 4, can we say the person is asthmatic?
Malampathic, sorry?
It's 4, malampathic 4. The score is 4. So can
malampathy.
We say,
okay.
Yes.
You're looking at the assessment for the throat for someone to be put to sleep. Is that what you're talking about?
Yes, please.
No. I mean, asthma is specific. This is what I'm trying to say. There are illnesses that look like asthma, similar to asthma, but not necessarily asthma. And I think one thing you can take into consideration is obstructive sleep apnea. Yeah, OSN, which can actually affect people, and obviously they wake up in the night with problems with breathing and things like that. So malampathy 4 is prevalent or not relevant to being put to sleep. It's more to do with the fact that somebody, the anesthetist who wants to put you to sleep for an operation or a procedure, would actually need to tread carefully when you're malampathy 4 as opposed to malampathy 1. Definitely not the same as asthma.
Okay. Thank you.
Thank you.
We've had a few questions that have come through social media as well, if we can try and do them in a quick fire way. So the first one, this parent has written in, my 15-year-old doesn't want to carry his asthma pump around. Obviously, that's very worrying. How can I convince him to keep it with him at all times?
Good question. Well, I mean, a 15-year-old, I would have thought, should be aware that asthma kills. And so therefore, it's not frightening them, but I think it's important to let them be aware. Again, educating them, probably getting them to the pediatric asthmatic nurse and finding out why is it he doesn't want to carry it. Is it because of a peer pressure? Is it because of a fashion? Or is it because he is not aware of the dangers or the benefits or the dangers of asthma, a sudden attack, and maybe the benefits of carrying it? It's important that sometimes it may be worth watching a movie together that actually depicts that, like I've just done the video. But there's a movie, I think if I remember, it's called The Hand That Rocks the Cradle. I don't know if anyone has watched it. It's a very good film where it tells you about asthma and the lack of the pump when it was the way they did it, they interfered with the pump. So the mechanism of the pump was, defunct, i.e. not functional. And she got the asthma attack and she was using it, as you know, to no avail. So it just goes to, and maybe that might, but it's important to get to understand the reasons or the rationale behind why they're refusing or they're not very keen on carrying. And if you address that, I'm sure it'll get better. The other thing that might help is maybe, I don't want to say bribing, but giving them something they like that would reassure them that if they carry it, they live.
There's some good suggestions there. Yeah, definitely trying to understand what's going on in that 15-year-old's mind, and even bribing if necessary to save lives. So the next question, our house has mold. I've been cleaning it with bleach, but this seems to affect my child's asthma. The landlord's not helping. What's worse for my child's asthma, you can say? Is it using bleach or being exposed to mold? Do you have any advice about this?
Well, for starters, if you're renting and your landlord is reneging from the contractual obligations, then you need to be highlighting this. You need to be taking the appropriate measures because you're the one that is suffering with the child. There's no questions about that. Bleach, obviously, if you find that bleach is adverse in terms of affecting the child, then perhaps use less of it. Or if you use it, then maybe aerate the area. Make sure at least the windows are open and, and keep the child away from that until those fumes are actually gotten rid of. But of course, there are less abrasive agents, cleaning agents that you can use. So if you know this particular one that doesn't go well with the child, or the child doesn't do well with that, then maybe change it to something that they can do well with. But more importantly is solving that problem. Your landlord has the obligation, has the absolutely contractual obligation to look after the tenants and their living conditions. You have your MP, you have your councillor, you can approach them. And you can actually, I don't want to be pointing fingers, but you can go to the press, because this should not be happening.
Gosh, a lot of sympathy there for that difficult situation you find yourself in, and keeping records, whether photographs of the mold, if your child is going into hospital, anything like that. Write letters, document them, send emails if necessary. We've got the hub here, and I think there's another question from the hub if you'd like to unmute yourself.
Yeah, hi. I'm just interested to know what's actually in the inhalers, the pumps. I don't have asthma, but I'm just interested to know what is actually in them, what people are actually breathing in.
I mean, well, the inhalers are bronchodilators, and there's others that have steroids in them. And as I say, for me to go through that would take a long, long time, what it is. But it's, if you have, imagine what you have with an asthma attack. The bronchs, i.e. these muscles with the rings in the lung, do constrict, as I showed you. They swell. And when they swell, they cause problems. The inflammation causes mucus to be released. And so therefore, the bronchodilator, which is the pump, would actually relieve that. I think I showed it in the picture there. I can go back to it if you want to see it, but it did show that you would see what it is like. It doesn't completely take the swelling down, but it at least allows for you to have a breathing space, for you to be able to breathe and do your normal thing. And of course, by the time the swelling settles, then you can go back to normal. But then they have the ones that are steroids. So the steroid included in the inhaler, in the pump. And that is to help, because the steroids are the mainstay of the treatment of asthma. And this is why the complications of asthma are plenty. People end up with skin problems. People end up with bone problems. People end up with the pancreas. So we tend to use the inhaler. If that gets it better, i.e. the one without the steroid, then that's fine. But if you need the steroid, which is what would dampen the inflammation, then that's what we would give. But again, when it's under control, you wouldn't need that. That's why it's a short, sharp course. I don't know if I'm making it. I can't go through the details of what each and every one has, because they're all different. There's some that are powder form. There's some that have the steroid in the liquid form.
That sounds really good. Thank you. We're also having a lot of information that's coming through the chat. For the person who is worried about property, and this might be relevant to other people as well, please remember, in the UK, we've got the Ombudsman, that you can always get in touch with Citizens Advice Bureau, Shelter, and actually there's Khan Advocacy. So if you send an email to advocacy@khan.org.uk, they'll be keen to help you more with that sort of issue with your house. We've got some questions about whether, for people who want to reduce the risks of asthma, someone says asthma runs in their family. They're concerned about their child developing chronic asthma. Is there anything that they can do? Someone else asked a question surrounding any natural health foods or refreshments, anything to help reduce symptoms. Do you have anything like that which you can suggest?
Obviously, it's a question of where you have, when you have nature versus nurture. If you have, the genes are there, then, they may skip a generation and you might be lucky to avoid it. But if you do have that, then all you're going to do is look after yourself. Make sure you control it the best. I mean, being asthmatic does not mean you are assigned to the scrapyard. No. Apart from that, as I say, again, I say the same thing. Like, for example, again, I'm digressing, but someone who's got sickle cell anemia, they know what they need to do. Yeah, they definitely know they should not be exposing themselves to colds, the living conditions, the food, the sleeping, because exhaustion would make you more prone to triggers. If you see what I'm saying, going like the weather is up and down, and you're thinking, yes, I'm in Ibiza when you're in England, and it's so all of these things, weather conditions, food, the kind of lifestyle you live, smoking, alcohol, the kind of work you do, stress related, and all of that. So it's more like lifestyle changes, developmental changes that you have to make. And of course, sometimes some sacrifices you have to make for your children or for your family. So these are all in a group, there's no one panacea, like a silver bullet. No, it's something that fits you and fits you only. It may not be the same for the next person. So try and get your healthcare worker, the asthma nurse, specialist nurse, who will sit down with you and go through the plan. I keep saying that plan is important, because when you get the plan, they'll be able to monitor that. They'll be able to look at what is happening within 6 months. And if at all they know this is not happening, then the respiratory specialist is there to help.
Thank you very much for answering that. We've just got a couple of comments about some symptoms. So we've got someone who has just mentioned silent asthma, which is asthma where a wheeze might not be present, which might not be classical symptoms. However, you might respond well to asthma treatment. Just to remember, yes, not every single asthmatic person will always sound wheezy. And then we've got questions about someone who says they've in conversation, they get a raspy voice and they feel a bit short of breath, whether that could be related to asthma or whether snoring could be a sign of asthma.
Well, I mentioned snoring, I mentioned obstructive sleep apnea, OSN. Yeah. If you think that is affecting the partner, affecting where, your way of life, i.e. your work, you wake up in the morning, you're tired, you can't function, you have to then sleep during the day and all that. And at night, you're definitely waking up with, so that needs to be checked. That needs to be sorted out. You either would need a respiratory physician, somebody who looks after the chest. They'll go through a battery of tests with you, and they'll be able to nail it down. They've got the spirometry we talked about. They've got the other tests. All of these could be done. What he needs is for you to go to the GP, and the GP will assign you a nurse, and that nurse will look after you. And then, of course, the specialist who is in the hospital will take care of that. It's as simple as that. And the good thing here is you don't have to pay for it. It's not like, in other places we know where it's free. You can actually access it wherever you want to be, wherever you are in the four corners of England, Scotland, and Wales, and Northern Ireland, you can do that. Yeah, so it's there for you. Just spare a thought for people in America who have to pay tens of thousands of dollars for this. So we're thankful for the NHS, and this is where we are. It's important that now the silent asthma you're talking about is important. Like I said, there's no one symptom that is specific or definite to say this person has got an asthma. It's a combination. It's all of the things that I talked about, not just one. And if you're talking about silent asthma, well, maybe because it hasn't been diagnosed. That's why it's silent. Yeah. But when you talk about silent, my worry is asthmatics can go into what we call a silent chest. Now, that is a dangerous thing. Yeah, a silent chest is close to death. And in a child, once they get to that, the likelihood of recovering from that is very, very slim. So I urge you, I implore you, I really, really ask you to look after the kids when they have the asthma attack, give them what they need, the pump. And if at all the pump is not working after the third attempt, please, 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 and pretty please, get the ambulance.
And can I quickly ask, okay, for the older people here who are watching, is asthma something that can be diagnosed in later ages?
Yes, it can be. It can be, but then you've got to then be specific about it. Is it cardiac asthma? Is it COPD? You see what I mean? So it masks itself in that umbrella of respiratory illnesses. And this is why it is important for the respiratory specialist to do their work, to do his or her job by actually going through all the, the history, the physical examination, the tests, and of course, coming to a diagnosis as to what it is.
Dr. Kamara, Thank you so much for all this information and for answering all the questions. If people want to connect with you, what's the best way for them to do that?
Well, Khan is my second home.
So you can find Dr. Kamara through Khan. I'm Lizzie on Dr. Liz London. This has been our health hour today on childhood asthma. I hope you've learned something and hope you've learned something that you can share and you can look out for asthma around you and think about how you can better look after the people who do have that condition and spot it. We're going to hand over now to Trisha. Thank you.
Thank you, Dr. Kamara, and thank you, Dr. Lizzie, for taking the time to join us today and sharing your knowledge. I learned a lot personally, and I believe it's something that is worth sharing in the community. Thank you, everyone, for joining us today, and I hope that your questions were well answered, and I hope that this session was also helpful and impactful to you as well. So I'm just going to share my screen. We have a few more information that we'd like to share with everyone before we go. So please give me a minute. Kindly let me know when you can see my screen.
Yeah, we can see your screen.
All right.
Yes, we can see. Trisha, can you look at the chat as well, please?
All right. Okay, so we have the Black Community Health and Wellbeing Day ongoing today up until 4 p.m. in London. So it's being organized by the London Inspire program. So if you can make it, if you're here, you're joining here from London and you can attend the Black Community Health and Wellbeing Day, we encourage you to go and, invite someone to join you as well. All right, so we have our weekly health hour. Oh, sorry for that. We have our weekly health hour, which takes place on Thursdays. I'm sorry, on Tuesday. Sorry, I think I'm reading something wrong. Yeah, so we have our health hour, which is next week, Saturday, 13 July. So it's taking place from 11 to 12:15, and we're going to be talking about managing burnout and strategies for a healthier and balanced work life. Please take time to register by emailing info@can.org.uk or scan the QR code above, or you can visit our website. So it's there on my screen. If you can take a picture of it, that would be helpful, and register to attend. My screen is moving a bit fast today. So next, we have our Black Healthcare Awards, which is taking place in London. So it's to focus on Black healthcare professionals of the Caribbean and African diaspora. So please, you are invited to join us on that day as we celebrate our Black healthcare professionals. So if you are interested in attending, you can scan the QR code on the screen. It's taking place on Saturday, 27th of July at the Plaza Park Westminster Bridge in London. So if you're here from London or you're even here in Manchester, take time to book your tickets, and we hope to see you as we celebrate Black healthcare professionals. We also have our special legal drop-in. So this is being organized by our advocacy department. So we do organize legal drop-ins and other sessions in a month, every other month. And this time we are focusing on UK criminal law. So if you know anyone that is possibly facing anything, criminal law related, so maybe stop and search, antisocial behavior, protest, or even representation at the police station, this is the right time to join. So you can register on our website, which is can.org.uk, or you can scan the QR code. So I'd encourage you to take a picture of the QR code if you can, and scan it, share with your friends and family, anyone that you know is going through any criminal law proceedings or they need a solicitor to speak with. So this solicitor also does he also does legal aid as well. So if you think that you need legal representation in any criminal matters, please would encourage you to register for this session.
Then we also have PAWS. So that's our Physical Activities and Wellbeing Club. So if you're looking for ways to stay fit and in the process meet friendly faces, please join us. The PAWS Club is free. It's on Mondays and Wednesdays. Please join us, or for more information, just email pawclub@can.org.uk or contact the number on the screen. And if you're interested, just contact these numbers or the email address, and we will get in touch with you. It's very interesting, and we encourage everyone to join. And last but not the least, we have the Homes for Health project that is taking place in Gorton. So during the session, we had people talk about how the housing conditions is affecting their health, and it can even exacerbate issues like asthma. So the CAN advocacy team is the CAN advocacy team is in charge of this project. So if you're facing any housing issues and it's even affecting the health of, your child or even yourself, please contact us at advocacy@can.org.uk, and we will be there to support you and advocate on your behalf to make sure that your landlord does the right thing. So that's it for today. Thank you all for joining us, and we hope to see you all next week. Thank you all. Thank you all for joining us. Have a lovely weekend.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.